All right, well, it looks like we're right at noon. So want to welcome everybody who's joining us for another Department of Medicine Grand Rounds. And just as a reminder, if you have any questions, feel free to put them in the chat. I'll be monitoring that for Dr. Hisama, who I'm very excited to introduce. Dr. Hisama is a professor of medicine in the Division of Medical Genetics and a program director for the Medical Genetics and Genomics Residency. He's also a medical director for our Adult Genetic Medicine Clinic and has too many numerous influential publications to recount. But on top of that, has also been named a top doctor in medical genetics by Seattle Magazine and is incredibly active in promoting diversity and equity and inclusion in medicine. So incredibly lucky to have her here today to present with us. And so I'll hand over the podium to you to take it away.
Thank you very much, Dr. Crum. Good afternoon, everybody. If we haven't met, I'm Fuki Hisama, and thank you for that generous introduction. It's always a pleasure to talk to my home colleagues in the Department of Medicine here, and I checked and it's been about 3 years since I've talked about medical genetics, so it seems like an excellent time for an update to talk about my vision as well as the challenges and opportunities for the future of genomics and precision medicine. Let's see. Okay. So first of all, I was asked to show this disclosure slide, which, as you know, is mandatory. So I have no conflicts with respect to this talk. Okay. So what I hope that you come away from today in about our hour or so together is to learn the difference between genetics, genomics, and precision medicine, to understand the 5 possible results of any genetic test and why variant interpretation is clinically important and a big challenge in the field. Next, for those of you who are primary care providers, especially the residents, I'd like you to identify which patients can benefit from our specialized genetic services and know how and when to refer. Finally, because I get a lot of questions about direct-to-consumer genetic testing, I'd like to touch on that for a few minutes. And then finally, I'll close with talking a little bit about gene therapy. Okay. So I like to think of the history of medical genetics in this way. So beginning in about the 1950s with the discovery of the double helix structure of DNA, we really started to launch the era of genetic medicine. And really we were focused on diagnosis. Currently, we're in the era of genomic medicine, where we actually have access to be able to interrogate all of a person's DNA or their entire genome. And we are beginning to implement that into individual patients' care. And so precision medicine really means implementing care for patients at an individual level and incorporating their unique DNA into their care decisions. So I'd like to start out the talk today by sharing with you the story of a patient whose care I was involved with about 9 years ago. So this was a 30-year-old man who had recent diagnosis of type 2 diabetes, and he presented with a 1-month history of cough and dyspnea. He came to an outside hospital with tachycardia, hypertension, diaphoresis, and tachypnea. He was intubated, his ejection fraction was very low, and he unfortunately suffered cardiac arrest. So he was transferred to UW Medical Center for cardiogenic shock and possible LVAD. Unfortunately, after his arrival here, he developed multi-organ failure and died 2 days later. There was an autopsy performed which found that this patient had bilateral pheochromocytomas as well as a number of neuroendocrine abnormalities. So the autopsy diagnosis was catecholamine-induced cardiomyopathy secondary to his pheochromocytomas. The director of the autopsy service at that time, Corinne Fligner, actually contacted me after she performed the autopsy and asked me whether what he had could be genetic. So basically, what I reviewed his chart and then I recommended postmortem genetic testing for 2 genes, the VHL gene causing von Hippel-Lindau and the RET gene causing multiple endocrine neoplasia. So basically, I like to think that this is me with using a very targeted approach to genetic testing after a very thorough evaluation. And so it turned out that his VHL genetic testing was indeed diagnostic and confirmed the diagnosis of VHL for this patient here indicated by the arrow. The RET gene, the second gene that I recommended testing for, was negative or normal. And then finally, I actually ended up seeing 6 members of his family for genetic testing. And the results of that testing were that both of his parents and all of his siblings tested negative, meaning that they themselves are not at risk for VHL. And this was due to a new mutation, presumably in this patient, which does account for about 20% of VHL. Next, I'd like to share with you what's often described as the first case of a patient who was saved by genetic sequencing. And so this is the story of Nicholas Volker in Wisconsin. Around the same time as the patient that I just presented to you, he was 15 months old and had failure to thrive and developed perianal abscesses. He unfortunately had a very long protracted course, was thought to have presumptive Crohn's disease and had many surgeries as well as ICU stays. He was treated with a number of immunomodulating drugs, and he also continued to develop new fistulas. He did have targeted genetic testing for 6 known immunogenetic diseases with the thought that he could have an inherited defect in his immune system. However, given the severity of his disease, the inability to make a diagnosis, and the long-term effects of these very powerful treatments, the IRB at his hospital approved exome sequencing for diagnosis. And again, remember that this is only about a decade ago, so this was still considered to be, quote, investigational. And so rather than this sort of approach of peeking through the keyhole and trying to select just 1 or 2 targeted genetic tests that the clinical geneticist thinks is the possible diagnosis. Instead, they used a whole exome sequencing approach, or sequencing 20,000 of this boy's genes. The IRB approved the exome sequencing on an investigational basis for this child, and the cost at that time was about $75,000. Now, I will say that in this case, when you sequence someone's exome, then this is really not like finding a needle in a haystack. It's worse than that. It's really like trying to find a needle in a stack of needles. And so, for example, for this child, they found over 15,000 variants in his genes, and then they started to filter them using bioinformatics approaches. So I won't go through this all with you, but they basically thought that this was the most likely candidate, is a missense substitution in the X-linked inhibitor of apoptosis gene, or the XIAP gene. So this gene does have a known function. It's associated with hemophagocytic lymphohistiocytosis. So basically they operated on the principle that they thought that there was an activation of his cytokines via NOD signaling. They went on to do some functional studies of his particular variant, which confirmed that there was increased cell death in an apoptosis assay and increased IL-8 expression. So based on his progressive course and this presumptive diagnosis, they went ahead with an allogeneic hematopoietic stem cell transplant for him. And 42 days after he underwent the transplant, he was eating. And 5 months after the transplant, he was healthy. And this is a picture from one of his surgeries, and you can see that he has very persistent non-healing fistulas. So this is Nicholas a year after the transplant. Okay, and this is him 6 years after the transplant. And he was the subject of this book, 1 in a Billion, which was published by 2 reporters from the Wisconsin Sentinel Journal, the local newspaper, and they actually won a Pulitzer Prize for their reporting of this story. So this is really a remarkable example of precision medicine and applying information about an individual patient's DNA to their medical care. But how close are we at this point to precision medicine more broadly for patients? So this is the current model of medicine, and I want to thank Les Biesecker from the NIH for sharing this slide. But basically, currently in most of our medical settings, we wait for the patient to become sick and present with a problem. And then we go through our time-honored history, exam, differential diagnosis, select testing, diagnose them, and then treat them. And I think everybody in the audience is familiar with this. But what if we're actually able to initiate testing, such as genetic testing, earlier in the course of the disease, and then do a targeted history and exam and treat the patient before they become sick by preventing their disease. Wouldn't that be wonderful? And again, this is a concept from precision medicine. So one of the opportunities that I'd like to share with you today is that we think of many genetic diseases as being rare, but really rare diseases are not so rare. Oh, so what is a rare disease? This was defined in 1983 by the Orphan Drug Act as a disease that affects fewer than 200,000 people. And most of the diseases that fall into this space are hereditary in nature. So since there are over 7,000 individual rare diseases, there are an estimated 25 to 30 million people in the United States who are affected by rare, again, largely genetic diseases. So this is a vision for rare diseases. Basically, we have the opportunity with genomics to identify patients who are at risk for these diseases. We could implement screening or prevention for a number of these diseases, again, leading to early treatment, saving in time for the patient. These patients are often on what we call the diagnostic odyssey, with a many-year delay in them achieving a diagnosis, and cost to the healthcare system. The savings would be tremendous. So the challenge of implementing precision medicine for patients like Nicholas and like the patient that I presented to you are really finding that patient, this yellow tulip in a sea of red tulips. So I want to share with you a resource for patients with rare diseases, which is the Undiagnosed Diseases Network. And the mission of the UDN is to solve medical mysteries through team science. So this is a map of the UDN site. So there's a network basically of clinical sites supported by a sequencing core and a central application portal, as well as there's a metabolomics core and a model organisms core. So the University of Washington is the center for the Pacific Northwest site. So any patient with a rare disease can apply to this program, and any physician can apply on their patient's behalf for a patient who has a rare, heretofore undiagnosed disease. So this is the team here that is leading the PNW, Pacific Northwest UDN site. So the PIs are Gail Jarvik, the head of medical genetics, and Katrina Dipple at Seattle Children's Hospital. The lead clinicians are myself, Sirisak Chunprasert, and then on the pediatric side, Mike Bamshad, Division Head of Pediatric Genetics, along with Katrina and Ian Glass. And we're supported by bioinformaticians and genetic counselors and research coordinators. So does the UDN make a difference? There has been about 15 years of history with the UDN because this started initially as one site at the NIH, and then it was so successful it was expanded to other sites across the country. So these are the data from the first 10 years of the UDN, which show that of these patients, about 1,500, 40% were accepted into the program. And of those patients, about a third received a diagnosis through the UDN. And again, remember that most of these patients had been on a many-year diagnostic odyssey, had seen multiple specialists, and still not had a diagnosis. So interestingly, the UDN approach relies on really intensive clinical review first, before, and making a plan before doing exome sequencing. So about a fifth of the patients are actually diagnosed just on expert clinical review by a multidisciplinary team. The remaining 80% are diagnosed on exome sequencing or genome sequencing. And importantly, about a third of those patients had actually had clinical exome sequencing done previously, which was non-diagnostic. But the UDN has additional resources at its disposal, which enable identifying, for example, new genetic syndromes, which have not been discovered before. Again, any patient of any age with a problem in any organ system can apply for the UDN, and these are the top reasons for referral to the UDN. Okay, so again, what can primary care providers do? I think the first and most important thing is among the patients that you're already seeing, just to learn to recognize the red flags for what could be a genetic condition and think about referring to genetics. So of course, the first thing would be a family history. So if you ask whether other people in your family have this, and there are multiple people either in one generation or more, it could be genetic. Having 2 or more congenital anomalies or birth defects is frequently genetic. That usually presents in childhood, of course. And then extreme presentations of common diseases. So colon cancer at 30, bilateral breast cancer, bilateral renal cancer is more likely to be genetic in nature than conventional colon cancer at 70 or unilateral breast cancer in an older woman. Neurodevelopmental delay in children or neurodegenerative diseases in young adults are frequently genetic. Exceptional pathology like the pheochromocytomas in the patient that I mentioned to you who came to autopsy, and extreme lab values are all indications for genetic evaluation. Okay. So who do we not want to see in genetics? Patients who have subjective complaints without objective findings are generally considered not good candidates for the UDN. Patients who have a common sporadic disease, it's most likely we probably won't be helpful for those patients. If they have not yet seen an appropriate organ-specific specialist, there was a real fad several years ago for patients to have genetic assessment for a gene called methylene tetrahydrofolate reductase, and we don't see patients for that because what they have there is typically a normal benign variant. And we also don't interpret direct-to-consumer genetic test results like 23andMe, with the exception of high-impact pathogenic results, such as might come up on BRCA1 and 2 testing through 23andMe. So I've talked about rare diseases. Let's turn to common diseases. So by this, again, I mean diseases that affect more than 200,000 people. So where are we when it comes to genomics and common diseases? Okay, so I'm going to start actually with the concept of population screening or widespread screening in all patients for rare diseases. And the best example of this is really newborn screening. So in the state of Washington, according to the Department of Health, almost 90,000 babies were born in 2017. The Department of Health routinely screens for 28, again, primarily genetic disorders at birth in all babies, and this is done by the heel prick with blood spots on a card. And so these disorders are screened either by DNA testing or by GC tandem mass spectroscopy. So of those nearly 90,000 babies, about 200 were diagnosed with a rare disease, so less than 0.25%. But they were referred for specialized care, such as for disorders like phenylketonuria. And again, that referral is life-saving because it means the difference between a child who has lifelong severe intellectual disability and a child who is normal. Okay. When it comes to doing widespread genetic testing for common adult genetic diseases or in the adult population, I think it becomes a lot more complicated very quickly. And these are some of the important questions that I think would need to be addressed before implementing something like this. So of course, there's always the cost and the prevalence of the disease, as well as, is this a preventable disease where if you diagnose it, is it going to make a difference in their management? It's always important to consider the positive and negative predictive value of any widespread screening test, as well as the impact of ambiguous results. And I'll talk about that more in a minute, and the impact that those types of results can have on families and the cost to them and the medical care system. Are there any adverse effects or unintended consequences of more widespread genetic testing? And then finally, again, tying it back to treatment and prevention. So in the past few years, massively parallel sequencing, or what's called next generation sequencing, has arrived. And basically for the purposes of this talk, I think it's just important to recognize that it is now possible to sequence all of your 20,000 genes within about a week. And there are actually some protocols in newborn ICUs where they do what's called rapid exome sequencing, and they get results back within about 72 hours. And again, if you think back to the time of the Human Genome Project, when I was just entering the field of genetics in the 1990s, the Human Genome Project took a decade to sequence a handful of people's genomes at a cost of billions of dollars. Okay. So this is a slide which a lot of geneticists show in their talks because it basically illustrates how rapidly the cost of sequencing someone's exome, which again is the 20,000 genes in the coding part of the genome, or sequencing all of a person's 3 billion bases of DNA, their genome costs. And again, so currently we are somewhere around, hovering around $1,000 for the cost of the sequencing itself. Okay. So for adult genetic diseases, I think that there is now an opportunity to identify the people with rare genetic disorders from the background of common genetic disorders. And this does give opportunities for earlier diagnosis and prevention of disease with genetics. So the two examples that I like to use, the first one is colon cancer, of course, colon cancer, and the second one is breast cancer. And of course, both of these are in the top 10 cancers diagnosed in the United States annually. Only about 5 to 10% of these are what we call monogenic or inherited as Mendelian conditions. And the most common known genetic cause of hereditary colon cancer is Lynch syndrome, affecting about 1 in 400 to 500 people. And for hereditary breast ovarian cancer, the most common causes are pathogenic variants in the BRCA1 and BRCA2 genes, with a prevalence of about 1 in 200 people in some recent large-scale population screening studies. So if we think about Lynch syndrome as an example of rare among common, then this is the general population risk here, the red line, for colon cancer over a person's lifetime. And then this is the increased risk of colon cancer. This top black line is actually it's essentially 100% risk for people who have a different hereditary colon cancer called familial adenomatous polyposis. Okay. Next, we now have big data from these large genomic data sets, and we have tools to start answering questions in genetics that we've never had before. Okay. So one of the questions is actually how many variants are there in the human genome? So out of those 3 billion nucleotides, it turns out that each of us differs from another person by 3 million. So that's a lot of variation, and about 36,000 of those variants are in our coding regions. And again, we still think the coding regions are the most important parts of the genome when it comes to risk for certain diseases. So another important question is how common then are medically actionable incidental variants? So things that you weren't expecting to find, but that we know are important genetic risk factors for disease like BRCA1 and BRCA2. So that brings me to the topic of the possible results of any genetic test. So genetic tests are not just positive or negative, there are also gradations in between. And this is the currently accepted terminology for describing the result of genetic testing as endorsed by the American College of Medical Genetics and Genomics. So at the top, a pathogenic variant is one that is known to cause or increase the risk for a certain disease. A likely pathogenic variant implies that we're about 90% certain that this variant causes disease, but there's still some room for doubt. We have a large bucket of variants which are considered of uncertain significance, and anybody who orders any amount of genetic testing becomes familiar with this category very quickly. But it really means that we don't know if this causes disease or is this part of the normal background genetic variation, what people used to call polymorphisms, but we don't use that term for rare variants. Any variant can also turn out to be likely benign or benign, meaning we are certain that it's normal. Okay, so here's the problem. Calling a variant of uncertain significance is really fraught with challenges. If you call a variant of uncertain significance, if you upgrade it to something that is pathogenic, that would be considered a false positive, and then you may be subjecting the patient to invasive things like an ICD or colonoscopy, or at the very least unnecessary screening and increasing their anxiety about a risk for a disease. If you undercall a variant, if you say this variant of uncertain significance, I don't think it's meaningful, and so we're going to treat it like a negative, then of course you're at the risk of undertreating, and this could result in a cancer diagnosis or sudden cardiac death for a patient. And remember, whenever we're talking about genetics, we're talking about variants that this person shares with their closest family members. So the problem of variant interpretation is multiplied by all of their relatives who have the same variant, and what would you tell them? Okay. So fortunately, there have been several committees which have started to look at and answer some of these important questions. So the first one is the American College of Medical Genetics and Genomics came up with a list of genes that they felt should be evaluated and reported if you're doing an exome or a genome for clinical purposes. And you can see that most of these genes are for adult onset diseases and specifically cause inherited cardiac diseases like cardiomyopathies or inherited arrhythmias, as well as increased risk for cancers. So another related important question is, how common are these medically actionable, what we'll call incidental variants, if you do large-scale sequencing in healthy people? And that question, the answer to that question really was not known because, again, we didn't have large data sets of sequence information for healthy people. So this was a study that was led by Gail Jarvik, again, who's the head of the CSER project. And so her group sequenced 1,000 individuals from the NHLBI exome sequencing project. She convened an interdisciplinary return of results committee that basically was met periodically to review these variants and to determine what the criteria should be for which genes are actionable or medically important and which variants then would be medically important. At this time, the ACMG criteria did not exist, so basically we started from scratch. So these are the criteria that Gail developed, which are largely mathematically based, I'll say, in terms of determining what is a pathogenic variant. And because these are, again, healthy people, there was a high bar for calling something pathogenic or that telling them that they're more likely to develop this disease. So as a committee, we reviewed almost 600 instances of about 250 variants. And these were actually variants that had been previously listed in some of the large genetic databases. But we actually went back to the primary literature to review the evidence for pathogenicity and then classified these variants according to our criteria. So the two important take-home messages from this research project were that 90% of variants that are reported in the literature, medical literature, as causing disease do not by our criteria. And the second important take-home point was that about 1 to 3% of the healthy people had a pathogenic or likely pathogenic variant according to our criteria. So again, these were things that we considered would be reportable to them and their doctors so that they could institute preventative measures. I also want to highlight another study by Gail's group and Laura Amendola, who's a faculty member and genetic counselor in the Department of Medicine Division of Medical Genetics, led this paper, which basically shows that if you have 6 labs and you give them variants, so you say basically, this is a variant, how would your lab classify it? This is another variant, how would your lab classify it? So you can see, so all of the labs can find the variant, they can detect it on sequencing, but what it means and if it's pathogenic or not is a different question. So you can see that for some of these variants, it's pretty easy and all of the labs agree that this is pathogenic. but you can see that for other ones, there is not concordance among labs, which means that if you sent a patient's blood sample to 6 different labs, you could get different interpretations as to whether that was a medically important variant or not. So basically then, again in this paper, the conclusion was that when there was discordance, that most of the variants were actually overcalled, or their pathogenicity was higher than it should have been. Okay. This is a paper by another group from Denmark, where they were looking at variation in long QT genes, and they noted that 1 in 20 of their controls had a variant that altered the sequence of a cardiac channel protein. And clearly this is too high to be disease causing, because 5% of people do not have long QT syndrome. So therefore the vast majority of these variants must be normal, and they call these background noise. So to summarize this part of the talk, we now know that about 1 to 3% of healthy people actually has an unknown pathogenic variant in a medically actionable gene. We also know that the current risks of widespread testing of healthy people include both overcalling and overtreating benign variants, as well as undercalling pathogenic variants. Clearly, the benefit to risk ratio is greatest for conditions like hereditary breast ovarian cancer, Lynch syndrome, and hypercholesterolemia, where there have been shown to be very effective preventative measures. And so this group of conditions has been classified as Tier 1 by the Centers for Disease Control, meaning they should be targeted for implementation. In 2015, President Obama announced his Precision Medicine Initiative, and the goal of this project is to enroll 1 million participants across the United States, and specifically to enroll patients who have been historically underrepresented in biomedical research. So when I say underrepresented in biomedical research, this is a broad term that encompasses not only racial and ethnic minorities, but also disabled individuals, prisoners, children, and so on. Okay. So the name of the program has actually morphed into the All of Us research program. And I do want to highlight that Debbie Nickerson as the PI, along with Evan Eichler and Gail Jarvik, are the PIs of a grant that was received for the All of Us research program of $28 million. So basically what this program hopes to do is basically not only combine exome or genome sequencing with improved outcomes for people, but also to engage the participants in a way that they have not been engaged before, using data from like Fitbit trackers and access to their medical records, as well as providing them educational information about diseases. And the reason that I'm here is I am not funded by this program, but I actually serve on the IRB for the All of Us research program. So to summarize this part, I just want to summarize the current state of genetics and genomics in medicine writ large. So I like to think of this in groups, and I would say for ultra rare diseases, like what Nicholas Volker had, or conditions like UBE5A, genetics gets an A to an A+. In other words, we have unprecedented ability to diagnose these diseases and beginning to have some precision medicine treatments for a number of these diseases. For rare diseases, which is the space where genetics has historically worked, so known genetic conditions like Angelman syndrome, Prader-Willi syndrome, phenylketonuria, again, here I would give genetics an A, because we are really excellent at diagnosing these conditions and often provide a medical home for patients with rare genetic diseases. For the group of genetic disorders that I call rare among common, so things like Lynch syndrome or long QT, where there's a much bigger group of patients who have something similar, but their problem is sporadic and not predominantly hereditary, I would say that we get a B. And the reason for that really is because currently we have the knowledge, we have the technology, but the difficulty here really has been implementation and getting the word out to patients who have not had the benefit of genetic services. And then finally, of course, the largest group of patients have very common complex diseases, things like obesity, asthma, diabetes, stroke, coronary artery disease, which account for most of the morbidity and mortality in the United States. So here again, I don't think that we can be that helpful in genetics, but I will say we can't be that helpful yet. Okay, because things like polygenic risk scores are currently being evaluated, and we may be able to give people a more precise risk of their estimate or how they may be able to prevent disease in the future. Okay. So another challenge that I see is that the question of asking whether healthcare providers are trained to provide medical genetic services and capable of doing this. So this was a paper that was published in 2005 in the Journal of Medical Genetics, and they basically surveyed about 1,200 physicians whose primary activity is patient care. And they surveyed them with a few questions to determine what their baseline knowledge of hereditary breast, ovarian, and colorectal cancer was. And so this is one of the questions from the survey. Your patient's paternal aunt or grandmother carries a BRCA gene mutation for breast ovarian cancer syndrome. Could your patient also carry this mutation? So I'll give you a minute to answer yourself, yes, no, or not sure. And I just will point out before I show you the answer that there was no difference in the correct response rate by age. So suggesting that younger physicians who had trained more recently were not more knowledgeable about genetics than their counterparts who had been in practice longer. And in addition, about half of these physicians had ordered this type of genetic testing themselves in the previous year. So again, your patient's paternal aunt or grandmother carries a BRCA mutation. Could your patient also carry this mutation? Yes, no, or not sure. Okay, so these are the answers as given by specialty that were surveyed, okay? And this is the correct answer. So you can see that oncologists did the best, followed by OBGYNs, but they're the only groups who actually cracked the 50% mark, okay? And the problem with this is then if you don't recognize that this is a dominant condition that can be inherited from the father, then you really won't know who in this family is at risk and should be offered genetic testing. So this is a paper that was published in the American Journal of Medical Genetics, where basically when any physician orders a genetic test, then there's a hold on it in the laboratory, and a genetic counselor reviews the order to make sure that it's appropriate before the sample went on for genetic testing. And so the conclusion of this paper was that about a third of genetic testing ordered by non-genetic providers was ordered incorrectly. And so that when reviewed by a genetic counselor, this saved the ordering institutions almost $50,000 per month total. And over here is a article that was published in the Wall Street Journal about a boy who unfortunately had sudden cardiac death, and then there was some genetic testing done, and there was a variant of uncertain significance that then was cascaded through the family and tested for. Unfortunately, that turned out to not be the cause of the boy's death. So again, that was overinterpreted by the cardiologists taking care of the family, again, with the best intentions to try to prevent what happened with this, what happened to this boy. Okay, so what is the solution? How do people learn more about genetics? So I do want to mention, first of all, that there is now a handbook of adult genetic Genetics and Genomics. That came out this year, April 2020. That was published by Elsevier. So full disclosure, I did write a chapter for this book, so I guess I will get some royalties at some point, but I haven't made any money from it yet. So I would say this is an excellent resource for people who are interested in learning more. I say sort of like what you can do now is make friends with a geneticist, talk to them, ask them when it's appropriate to refer, and thank you again for inviting me to give this talk to you today. But my very favorite solution is for you to think about becoming a medical geneticist. There is a huge unmet need for providers who are trained in genetics, and UW has not only a medical genetics and genomics ACGME accredited residency in genetics, but also fellowships. So if you are a medical student in the audience, think about a combined training in pediatrics and medical genetics or internal medicine and medical genetics. That's 4 years of residency following medical school. If you are an internal medicine resident attending this talk today, come and talk to me if you're interested about a categorical medical genetics and genomics fellowship, which is 2 years of training following residency. And for MDs or PhDs, they can actually do diagnostic testing, meaning like next generation sequencing. You can learn how to do that as an accredited lab fellowship and do diagnostic testing on patient samples. Okay. So I do want to talk for a few minutes about DTC for the reason that this is one of the biggest questions that I'm asked. And so far, 26 million people have had DTC testing. And you probably have heard that the FDA has approved limited testing by 23andMe for diagnosis, direct to consumer. There are some upsides to DTC testing, I do want to say. Obviously, it's convenient, even if people don't have access to healthcare or a genetics clinic or specialty services. Those who promote DTC will tell you that it gives patients direct access to vital information. And of course, it's inexpensive, typically less than $200. There are a number of risks or downsides to direct-to-consumer genetic testing. As I've shown you, genetic testing is inherently complex. With DTC or with clinical testing, it's possible to get different results or different interpretations from different companies, which can lead to misinterpretation. Normal results can lead to a false sense of security, or conversely, again, undue or unwarranted anxiety if the results are abnormal. And then finally, because our genetic databases are biased toward people of European ancestry who have had much more sequencing than people of other ancestries, DTC testing is less sensitive for people from Asian, African, or Hispanic ancestries. There are a lot of myths and misunderstanding about direct-to-consumer genetic testing. I'd say the most important ones for you to know about is that it is not the same as clinical genetic testing. It is also not considered a medical test. Even the people who promote this say it's for information only. There was a study published in Genetics and Medicine that 40% of results reported from DTC were false positives, and it is actually not more private nor cheaper than clinical genetic testing. Clinical genetic testing is frequently covered by insurance for certain indications, and the patient out-of-pocket cost is oftentimes $250 or less. Plus, through the clinic, you have the protections of HIPAA and the Genetic Information Non-Discrimination Act. This was an article that came out in the New York Times where a physician actually did 23andMe testing, and she was relieved by her negative result. Okay. But 2 years later, she was diagnosed with breast cancer. She came to a genetics clinic and she had a more complete genetic test, which was positive. And so this was actually a platform presentation at the ACMG meeting in Seattle here last year. And they reported that 90% of people who have a BRCA pathogenic variant would be missed by 23andMe's BRCA testing. Again, if it's positive, it probably is positive, but if it's negative, it certainly may not be a true negative. Okay, and I wanted to share with you the story of this man whose brother had DTC testing. So the patient grew up here in the Seattle area, very active. When he was 30, however, he was admitted to the hospital with congestive heart failure. He was told that his cardiomyopathy was from heavy drinking and told that he should stop drinking. However, over the next several months, he became lethargic, lost weight, and his family started to become very worried about him. So his father took him to urgent care. He was admitted for diabetic ketoacidosis at the beginning of December and hospitalized for 10 days. He was transferred to another hospital for exacerbation of his CHF. And again, he had a prolonged, complicated, difficult hospital course. But finally, he had a biopsy, a cardiac biopsy, and this was diagnostic in him. As his father told me, this was the aha moment as far as what the biopsy showed. Because this patient has hemochromatosis, and the biopsy showed iron deposition in his heart. So, hemochromatosis is an extremely common genetic condition that's inherited as a recessive trait and affects 1 in 300 people of European ancestry. The classic triad is bronze skin, cirrhosis, and diabetes, and it can also cause cardiomyopathy. Importantly, this is treatable and preventable with institution of therapeutic phlebotomy. I will say that this gene is on the ACMG 59 list of things that can and should be reported to patients if they're found. Okay, so this is the patient with hemochromatosis. Of course, his parents are obligate carriers, but they're not affected by hemochromatosis. But here's the thing. He has 2 brothers. And this brother actually had DTC testing, which told him this result before his brother became sick. The problem is that this genetic testing, in the absence of medical care or really an understanding that his brother was at risk for this, did not help this family, or certainly this patient. Okay, so the American Medical Association does have a policy on direct-to-consumer genetic testing that I want to share with you, which encourages patients to undergo genetic testing under the guidance of a physician or a genetic counselor. Okay, and that physicians should, of course, talk about the testing and the benefits and limits like they would with any test, but that the physician should refer to a clinical geneticist or a genetic counselor if the ordering physician is not able to answer questions about DTC genetic testing. Okay. I just want to spend the last few minutes talking about gene therapy or gene editing, because this is a question that I get more and more frequently from my patients. So there are some really important recent examples of success with gene therapy for hereditary diseases that have not previously been able to be treated before. So one of them is for spinal muscular atrophy. And in spinal muscular atrophy, a deletion of exon 7 of the survival motor neuron 1 gene leads to absence of expression of this protein, which then causes a progressive fatal neuromuscular disease, usually fatal by age 2. There now is a treatment for this disease, and really seeing the video, which is nusinersen, and seeing the videos of these children who are actually able to walk and develop normally is really quite remarkable. Okay, and this is the motor development of children who are treated compared with people who are not treated. Okay. And another example that probably certainly our colleagues and our pulmonary colleagues are aware of is triple therapy for cystic fibrosis for the common delta F508 mutation or pathogenic allele in the CFTR gene. So again, this particular pathogenic variant accounts for 70% of cystic fibrosis. And again, this is the FEV for people who are treated versus people who are untreated. And again, if you think back to just that the CFTR gene was only discovered in 1989, and to be able to have an effective treatment for it just 20 years later is really, really remarkable and should be celebrated. The challenges, however, of these new gene-based therapies include the cost, which is considerable, of course, and equity. So these are the costs for nusinersen. This is for another spinal muscular atrophy drug, but it only needs to be given one time. This is gene therapy for an inherited retinal dystrophy causing blindness. And of course, equity, meaning that these therapies should be available to all people who have the diseases, but how do we make that happen as a society and as a medical system? So to end my talk, I just want to say that genetics is ushering in the era of precision medicine. Not only do we have exome and genome sequencing for diagnosis, which we have not had before, but we can think about using widespread sequencing for prevention of disease. And then finally, we have genetically based therapies for an increasing number of genetic diseases. And I'm sure that you saw the Nobel Prize was awarded this week in chemistry for CRISPR. And so that would really be editing the genome itself for treatment. And again, we're not there yet clinically, but that, again, may be something that's coming in the future. Okay. So I want to end my talk by thanking all of my colleagues in the Division of Medical Genetics and also our colleagues in pediatric genetics. So this is the Division of Medical Genetics, when Arno Metulsky, the founder, was still with us, and George Stamm, the second division head of medical genetics, was still with us. And this is our more clinical group at residency graduation. Thank you for your attention. I'd be happy to take any questions.
Thank you so much for that fantastic overview, and there's actually quite a number of questions for you. One of them, which seems to be very popular, is given the false positive rate of the direct-to-consumer genetic testing, should those positive rates be, or positive tests be confirmed with clinical testing?
Yes, that is the recommendation.
That was an easy enough to answer question. And then there's another kind of practical question within the University of Washington system. Do medical genetics, do they do e-consults for if there's specific questions about a family history or testing?
Oh, that's a good question. So I have an approximate understanding of e-consult, so I don't think that we actually have it. It's something I would be happy to talk to somebody about implementing. Our solution so far is basically I tell people just email me or Gail, because that's what happens anyway, right? We also do have a genetic counselor on page, which is between 8 to 5 every day, Monday through Friday, so they can answer a lot of questions on the fly.
Fantastic. Yeah, that's a great resource, because I've known in clinic myself that questions come up and it'd be handy to have a geneticist on call. There's another question from the audience of where do you see the opportunities and challenges for economic evaluation and cost effectiveness in clinical genomics? You touched on it at the end a bit, but do clinical geneticists or physicians use results from economic evaluation to guide practice or prescribing?
So I think that's an excellent question, and I'll just preface my answer by saying that I am not a medical economist. That is not my area of expertise, but I think that is such an important area, right? For not only all of healthcare, but particularly around genetic diseases. Carlos Gallego, who was a genetics fellow with us, he actually did a study like that to look at earlier versus later genetic sequencing for patients who had colorectal cancer. And they look at the QALYs, the quality of life scores and things like that. So the bottom line of his paper was that genetic sequencing earlier on for patients with colon cancer was cost saving, right? But I think that I think these are such important questions, and I hope that somebody else who is more knowledgeable about medical economics will actually take this on as their area of expertise and research projects, quite frankly.
Yeah, that's a really important topic that we often don't think about or talk about enough, for sure. And another important question that came up, you mentioned that a lot of our genetic databases are more heavily with the Caucasian and European descent populations. Can you speak to any efforts that are being done or any work that's being done to try and expand our database to include a more diverse ethnic background?
Yes, so this is so important because it is because for all people to benefit from the advances in genomics, they really need to participate, right, in research and in databases. And of course, for certain populations, particularly ones who have been ignored or maybe actually been dismissed by traditional medical research, it's hard to build that trust, right? But certainly the NIH, it's one of the top priorities for the American Society of Human Genetics. They have put out statements, particularly within the last year, about the importance of diversity and the importance of really making sure that we have equally good genomic information for people of all races and backgrounds. I'll say that just to use the example of CFTR. So our cystic fibrosis testing in the past has identified the panels that are used. The standard testing can identify 90% of pathogenic variants for people of European ancestry, but more like 50, 60, 70% for people of non-European ancestry. So the ASHG and genetics testing labs have committed to, because it's easier now to do more comprehensive sequencing, to make sure that the genetic test is as effective for people from non-European backgrounds as it is for people from European backgrounds. So that's just a small example of how geneticists are really trying to make genomic advances more equitable and make sure that people of all backgrounds can benefit from them. But we need to get the word out. It's a big job.
Yeah, fantastic. And I believe that you published something on that order recently in the American Journal of Medical Genetics talking about just that. So clearly one important topic and one you're passionate about. So thank you for your presentation today and for all of your wonderful work outside of just the genetics world, but also diversity and equity and inclusion. So really appreciate that. And thank you for a phenomenal talk. Really glad to have you.
Thank you again. It was an honor to be invited today, and I really enjoyed it.
Of course. Well, hopefully folks can join us next week. We will have a great talk from a colleague from the University of Colorado. So another great talk lined up. So again, thank you, Dr. Hisama, and have an excellent Friday.